Hey guys, we'll be getting started shortly. We're just going to wait for a few more people to join us. Thank you. Hey guys, why don't we go ahead and get started? Let's begin with some introductions. Dr. Peters, did you want to go ahead and start for us?
Hey, I'm Greg Peters. I'm a family medicine doctor in Buchanan.
Thank you. Dr. Rexroad, would you like to introduce yourself?
I'm Carmen Rexroad. I'm a family physician at Pendleton Community Care in Franklin.
Perfect, thank you so much. And Dr. Fournier?
Family practice, changing Weirton.
Perfect, thank you so much. And Tracy Thornsbury?
Hi, I'm Tracy Thornsbury. I'm nurse practitioner, Williamson Health and Wellness, and I have with me Judith from our prior authorization department.
Perfect, thank you so much for joining us. Why don't we start down here?
I'm Rachel Mitchell. I'm a pharmacist in the specialty pharmacy here.
I'm Chris Hale. I'm with Rational Drug Therapy pharmacist.
John Gilchrist, one of the infection providers here.
Hi, I'm Mitra Mutasham, Project ECHO coordinator.
And I'm Carolyn Kidd. I'm a nurse educator with the Mid-Atlantic AIDS Education and Training Center.
I'm Caitlin Ettinger, one of the Project ECHO coordinators.
All right, perfect. And Dr. Peters, did you know which case you wanted to go ahead and get started with?
Yeah, it doesn't matter much to me. I mean, it's really up to you. They're all relatively straightforward, I'm afraid. So it's I mean, I had open 4694, the 36-year-old gentleman.
Okay, perfect. We can start with that one.
Okay.
And we have a lot of cases today. We can try to get through to see where we're at around 12:35, 12:40-ish.
Sure.
But yeah, why don't we go ahead and get started with that one? Pull it up for you. All right, can you see that okay?
Yeah, I've actually got it pulled up on.
Okay,
on
perfect.
So this is a 36-year-old gentleman diagnosed with hepatitis C. Kind of interestingly, actually, he came to me with this bilateral lower extremity vasculitis. That was just weird looking, and it didn't make a whole lot of sense. He endorsed a history of IV drug use, and as part of the workup for his vasculitis, I ended up testing him for hepatitis C, and it was positive, and we kind of went down the rabbit hole, got his vasculitis under control, and then kind of moved forward. And in the meantime of treating his I guess this workup, the restrictions on the medication have changed, and we're going to try to proceed with his with his treatment. So he's a 36-year-old guy with a BMI of 32 and a half. He has completed his Hep A vaccine series. He's had 2 of his 3 hepatitis B vaccines. His most recent labs are at the end of last year and are there. There's not a whole lot that's particularly exciting about him in that respect. He has a low AFP. His HIV test is negative. He has no evidence of ever having had hepatitis B. His fibrosis score is an F1 to F2, and his viral load is less than 1 million. His genotype is 1A. So for him, you know, he takes baby aspirin and Suboxone daily, and I've suggested for him Mavrite for 8 weeks because that's what would be preferred on his formulary and should cover him nicely, I think. I do kind of wonder if maybe part of his vasculitis was actually an extrahepatic manifestation of his Hep C. It certainly could be. I have really no other explanation for his vasculitis other than it got better and was just kind of treated supportively, and he did okay. So.
Yeah, thank you so much for that case. Did anyone have any questions or comments about that case? I wanted to ask everyone out there. Does anyone have any comments in here?
Hey, Greg. Good job,
Yeah.
man.
What's up?
Proud of you. Hey, just so my compliments that you worked up the vasculitis with the infectious, looking for the infectious hepatitis. That's great. Vasculitis is a funny thing. It can certainly come from various infectious diseases. So I kind of broaden this out a little bit. Obviously, hepatitis C is one of them. Hepatitis B is another one. HIV can be associated with vasculitis. Acutely, if the person's febrile, there's all sorts of acute infectious vasculitides, leptospirosis, rickettsial illnesses, a bunch of viruses. But really, if you're thinking about something that's like presenting as a leukocytoclastic vasculitis, I'm assuming, Greg, is like tiny lower extremity. Yeah, Hep B and Hep C and HIV are some of the major ones. So did he get cryoglobulins out of curiosity? Did you guys do cryos?
Yes, and yeah, they were negative.
They were negative. Okay.
Yep.
This is one of these nondescript vasculitises.
Yep.
I think the other cool point that this case brings up, and you're right, Greg, I have no idea if you could prove or disprove this is HCV related vasculitis, but you could certainly assume. We've seen it present as a cutaneous vasculitis. We've also seen this present, hepatitis related vasculitis present as larger vessel vasculitis, including the CNS. So remember that one. We've seen actually now multiple cases of CNS vasculitis from Hep C. And the only other point I was going to make is that remember this patient's fibrosis score is unimpressive, but extrahepatic manifestations and sort of fibrosis does not always correlate. So you can have somebody who is not a cirrhotic patient who can present with pretty nasty extrahepatic manifestations, including cryoglobulinemia and worse. So anyway, I think where do I rank this guy's urgency of getting treated? I put it on the, anytime you're getting any systemic manifestations related to this illness, it's probably a great idea to abort the process before it stimulates his B cells further and heads him down that direction towards a neoplastic process. So yeah, I think Mavrite's beautiful, man. Remember, for those on the call who are not used to prescribing these medications, Greg is a very advanced prescriber, obviously, of this. So his thought process that he went through not only fine-tuned it for the genotype, but in fact for the patient's insurance. So yeah, that's pretty good. So you could have given them 12 weeks of basically any of the drugs for genotype 1A. So it could have been Epclusa for 12 weeks, Zepatier for, you'd have to do NS5A polymorphism testing because it's genotype 1A. Maverick for 8 weeks or Harvoni for 8 weeks, given the low viral load and the absence of advanced fibrosis. You could give the shorter duration of Harvoni, but Medicaid has Maverick on the.
Is there any reason, John, like if for whatever reason, I don't know, if tomorrow the rules were to change or next quarter the rules were to change and they were to prefer Harvoni for this patient, is there a reason that you would do 12 weeks of Harvoni if you called the vasculitis an extrahepatic manifestation that doesn't change the duration of treatment really?
Not that I know of in the treatment in the trials, they didn't. I don't think they differentiated on people who are suffering with extrahepatic stuff. But great question. I know for years we talked about BMI being an issue, but Rachel's always pointed out that the trials had patients BMI up to almost 60 or something like that. I can't remember what it was. So, but yeah, I think any of the choices are fine. And I would place him on kind of the scale of people you were presenting today, probably on the higher end of urgency. So yeah, great job, man. Impressive that you thought of it to diagnose it in the setting of a vasculitic workup.
I'll be honest with you though, so our practice here with our company has changed just kind of as we've done this. It's not. I think starting this year, it would be a lot less so because part of our just basic lab workup for all of our new patients, and in fact, retroactively for all of our other patients, is universal screening for hepatitis C and HIV for every one of our. He would anybody would
Forget it, man. I'm giving you credit. No.
we're doing that because I said, but it's just yeah, anybody would have.
Great thought.
It's the right thing to do, though.
Yeah,
It sure is.
most of the time when we do see extrahepatic manifestations, it's in the setting of somebody with advanced disease. But this is a cool case that it doesn't seem to correlate. So, but yeah. The only other place I've seen vascular besides the skin is the brain, the CNS from HCV. I don't know. Have you seen any, Dr. Feinberg, any other? Usually skin. Yeah, usually cutaneous.
No.
Thanks, Greg. Yeah, I like it. Maverick to 8 weeks, unless Medicaid changes it 2, and then Medicaid, or then Harvoni for 8 weeks, whatever. So, yep.
Did anyone else have any comments or questions?
I do. This is Leslie from the Health Center Pharmacy in Virginia, and I was wondering, at what point do you guys usually do the screening for type 1A for with or without polymorphisms? Because some of the Virginia Medicaid paperwork, they're asking that question, and we don't normally do it. And I've tried to get it added on to our LabCorp order set, and what I'm being told by our higher up powers is that it's super expensive. So what do I do about that?
I think you're going to get opinions on this one. As a skillful's here at the hub, my opinion is don't check it unless you're going to try to use Zepatier, or however you say that word, Zepatier. We have a kind of expert here on it. I'd say Rachel has probably read and taught me the most about it, but some of our providers do check it at baseline. My reading on it is you don't do anything with that information, regardless of what it shows, except for Zepatier, so why check it? And that'd be my opinion, but we've got a couple other providers in here who might give you other thoughts. We do have providers here who check it routinely, but I don't think you do anything with it. So I would beg the question why we're checking it. But any other thoughts from you guys?
Oh, and in fact, I think that my understanding is that Merck is really sort of, because Zepatier isn't used that much, is Merck is really sort of pulling out of that market. But I totally agree with you. If it isn't in your plan to use that treatment, then looking for the polymorphism is a waste of money. I don't know why people are getting it at baseline.
It's giving confusing information because sometimes it can show resistance, but you still have
so many other options.
Yeah, and even
also we haven't shown yet that resistance in hepatitis C is the kind of permanent problem like it is in HIV, and that you have to work around it. So I would not check it.
The only time I check it is probably on somebody on dialysis that I have to use Sepetier.
Gotcha.
So otherwise I don't check it at all.
And thanks for bringing that up. So remember, Zepatier's corner of the market was the fact that they were the first ones to have dosing for like CKD and ESRD. And Rachel, have they not all got that now?
Pretty much, yeah.
I think
There's
all of them, including like even the ones we initially were scared to use was Epclusa and Harvoni in the setting of creatinine clearance less than 30, and that's now changed. They basically have opened up the restrictions from my understanding. You can utilize them down to severe CKD, probably even ESRD, I'm assuming.
Well, that's, and the problem was they were worried about accumulation of the sofosbuvir active metabolite, but they've basically shown that that's, yeah, it increases, but it doesn't do anything harmful from what we can tell. So there's no reason to restrict use of those either.
And that is new since we've been doing the echo. So when we first started, we were hesitant to utilize the sofosbuvir containing regimens in that setting. So but yeah, and Zepatier was kind of awesome when it came out from that perspective. Now feel free to use any of them.
Yeah, we've never tested it, but the paperwork actually says genotype, and then it asks specifically with or without. It doesn't even give you an option to even put that you don't. So what I do is I just mark the box no, and then I put not required for Mavorite or something like that. And of course I send in what I've got. And I haven't had any kickback and not get approved, but I was just wondering what you guys had found. So, okay, thank you.
Great question. Yeah.
We also got a couple chats, a few people saying they only check it if the insurance makes them, and they've had only 1 or 2 private insurance companies requiring it. So, did anyone else have any comments? I wanted to make room for another case. We have several in today, which is great, but if anyone had any further questions, feel free to email me or chat me. We can certainly have them addressed for you. So, Dr. Peters, was that, did that answer everything for you?
Yeah, perfect. Yeah, and I don't know how many you wanted to do today. I can do these are relatively short ones. I mean, really, there's not a whole lot with. In fact, I think they all have the same insurance. I think all these patients all have. I think they're all Medicaid.
Yeah. So we have some from Dr. Tierney as well. So Dr. Peters, maybe we can save a few of your other ones for next session if you're okay with that as well. Okay. Dr. Tierney, anytime you're ready, I can pull up a case for you. Did you know which one you wanted to start with? Oh, I think you might be muted. Sorry.
Yes, I am. Okay, sorry. I want to start with our 0157.
Okay.
And that's
Okay, anytime you're ready.
Okay. It's a 47-year-old male, white, with Medicaid insurance. He has never used any drugs. He's never snorted any drugs. Did have a blood transfusion from a car accident at 4 years of age. Didn't have a lot of details about that. He says that he may have had sex with somebody with Hep C. He doesn't know. He's not aware of sharing any contaminated items, but he's got too many tattoos to count. All of them are unprofessional, and all of them he received for the 17 years he was in federal prison. And ding, 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 we have a winner. Yes. Anyway, he was diagnosed during routine screening in our office in September of 2019. No evidence of cirrhosis, no previous treatment because he didn't know he had it. No biopsy, no hepatocellular carcinoma. Past medical, really, he has hypertension. He is immune to A, and he's got so far 2 of the 3 vaccines for Hep B. He is bipolar and does have some anxiety and is under treatment of a psychiatrist and is on medicine. His survey when we did this in January was 0 out of 27, but I don't know that he actually paid any attention to it. He denies drinking any alcohol. He does state that he will use marijuana from time to time. And he actually does not smoke any cigarettes or chew any tobacco.
Wow.
Yeah, I know, shocking. I think he's the person I've ever had that's true for. So his medications currently are Abilify, vitamin D, fluoxetine, hydrochlorothiazide, and tamsulosin. His BMI is a 30.6. So when we get to his labs, you know, white blood count's fine, hemoglobin, platelets, all of that stuff, it all looks fine. Right up until the point we get to his iron. Now his iron is 180, his TIBC is 320. His ferritin, though, is 723. And everything else is pretty much just as you would expect. His iron saturation is 56%, which is also elevated. But, and we do see mild fatty liver change in the liver, otherwise normal. His scan was an F1 to an F2, and his steatosis score was only an S1. So he's iron overloaded. And I didn't know if you guys had any thoughts about that, but I, of course, have done my iron overloaded in liver disease research. And his transferrin saturation is actually 56%, which, according to the research I've done, says I really need to test him for hemochromatosis, even though he has Hep C, and we know that Hep C is a reason for people to end up with iron overload. But I thought this one was interesting because I haven't seen a lot of real iron overload, and this one appears to be legit. Now, we're not having any symptoms of this iron overload, but the research that I did said regardless, if you're over 45% in your transferrin saturation, you really should test. And then evidence is that phlebotomy before the production of symptoms actually improves his long-term morbidity and mortality. And I've got this from the American Association or Society of Liver Disease Practice Guideline. So I went through all of that, and then I have another article from Hepatology, but I don't have that one right in front of me. So are there any questions about, or is there anything else I'm missing here?
Did you check an HFE mutation?
I'm sorry?
Did you check HFE mutation?
HIV mutation?
HFE?
Oh, I haven't yet. No, but I'm going to.
Okay.
I'm saying he's supposed to be for that. And because he was over the 45%, he's definitely I'm definitely gonna check for that.
Perfect.
I've already found the test number for it too. Every time I see him, that's the first test he's getting. And interestingly, his hemoglobin A1C is like 5.1. He's not morbidly obese, you know, so we're not having a metabolic syndrome here with this either.
I think checking a hemochromatosis genotype.
You said on his imaging he had fat infiltration. He has genotype 3.
Yes.
And you can have fat infiltration into the liver with genotype 3.
Yes.
And that fat deposit in the liver, whether it's from obesity or from hepatitis C or from whatever, you can get those increased iron saturation percentages.
Yes.
So as long as that HFE is negative, I wouldn't do anything with it, even if he's a carrier.
Yes.
Anyone else have any comments or questions?
There's a cool history of Hep C treatment is always fun to talk about. I don't know if it's fun. It's interesting. It used to really matter what the iron, when we talked about response to interferon, this would be a patient that kind of we'd almost phlebotomize regardless if they were HIV positive or not, because the interferon response rates were so terrible with high iron. And so it's funny, we used to check HIV, and even if it was negative, sometimes get their iron down a little bit to try to improve their response rates. But nowadays, I don't think it matters. You're just going to treat them regardless. Hey, remember by the way, 2 comments. Bursting with pride right now between Dr. Tierney and Dr. Peters. You guys are such advanced, such advanced level. We learn from you too. So appreciate it. Diagnosing this with from vasculitis in the first case and advanced iron overload workup for the second case. From my end, there's very little I can add other than genotype 3. Remember, you got limited treatment options. So Epclusa, Mavri. Remember, for the first case, someone asked about NS5A mutation checking, and I said, don't do it with genotype 1A unless you're using Zephyr. The one exception is genotype 3 if you have more advanced disease. So I don't think you need to do it in a treatment naive patient who is not cirrhotic or have an advanced liver disease. And this guy does not appear to either on platelet count, APRI, imaging, or fiber short. Everything's kind of comforting that we don't have a cirrhotic patient. So I don't think you have to check it. Katie, is that your understanding too? You don't have to do NS5A. But if you did have advanced fibrosis, this would be one of those situations before you used Epclusa. You have to do the NS5A mutation. At least you should. Just since we talked about resistance a little bit.
I completely agree with you.
Yeah, either 8 weeks of Mavreet or 12 weeks of Epclusa, and you're good to go on this one. And I agree. I bet the iron just magically gets better.
Okay.
When you treat them, but we'll see. See what happens.
That'd be interesting.
Yeah, maybe the HFE will be positive, but I don't know.
I'll keep you posted.
Was there an activity score on this one out of curiosity? Maybe you put it in there.
No, because it wasn't the lab. It was I did the fiber scan.
Oh, gotcha. Okay. Yeah.
Anyone out there have any comments or questions, or maybe a similar case at your location? Everyone's zooming in.
And then it's your call. My next 2 cases are pretty run of the mill. So I don't know if Dr. Peters has another one that's interesting, or if we just want to.
I have one, and I have 2 that are boring, and then I have one more that's interesting. I'd actually like to do the interesting one.
Do your interesting one. Yeah, do your interesting one.
We do have a didactic as well. I wanted to save room for that as well. So I was thinking maybe if we had time at the end of that, we could maybe do another case. Is that okay with you guys? We can say.
Yeah, I mean, you're not going to hurt my
It's fine.
feelings. You know what you do.
Well, we might have time for
right.
it too still. So, but okay, thank you guys so much. Again, if there are any questions about that second case, feel free to ask me through email or the chat, and we'll have them answered for you. But anytime, Chris, if you're ready, I can pull up your didactic. Great, thank you guys. Do you want a controller, or would you like me?
You want to? So just a little intro of who I am again. I'm Chris Hale. I'm the Assistant Director of Rational Drug Therapy. We are the prior authorization vendor with West Virginia Medicaid and with PEI and CHIP. So I'm going to talk a little bit, focus on Medicaid insurance coverage for Hep C and HIV. With the PEI and CHIP, we don't cover those. We do the non-specialty medications, so we don't have any hand in the approvals for those. So we're just going to focus on West Virginia Medicaid. Kind of what I'll go through. I'll first show you, if you haven't seen it or if you're not familiar with it, like Medicaid's website, where to find all this information. So if it ever does update, you'll be able to see for yourself where all this information is. Go over the Hep C criteria. I know we have some people from Virginia here, so I was going to show a little comparison to some of the bordering states and how their Medicaid coverage might differ. And then go over quickly the HIV medications and the Ryan White program, which is also billed with the Medicaid ID number through that program. So the first few slides will be kind of the just for reference. Yeah, next slide. So this is the main page for the pharmacy. The link is there. The two main links from there, you can see in that blue ribbon across the bottom of the header, has the links for PA criteria and preferred drug list. That's where you're going to find most of the information. Next page. For the preferred drug list, if you click that link, it's going to look like something like this. It has the last 5 years of archived preferred drug lists. You want to click probably the one that's the most recent, which is always going to be in the top left corner. And that'll bring up a PDF of, in the next slide, I'll kind of show what that looks like. It opens a PDF. The left-hand column will have the preferred medications. In the middle column, you have non-preferred medications. The right-hand column usually has like class criteria. You also have some class criteria across the top of each header of the class. In the most recent file from January 2020, the Hep C treatments are on page 36. Antiretrovirals on pages 24 to 26. The next page here has the example of what one of those would look like. So this is the Hep C preferred drug list. You can see here there's the class criteria. It kind of links you to the full PA criteria where all the nuts and bolts of everything is located. You can't fit like everything from the PA criteria on this page. But you can see they list the preferred products of Epclusa, Mavorite, Ribavirin's on there, Zepatier as well, and then you have all your non-preferred ones too. Then if you go to the next page, you can see the PA criteria page is where you're going to see all of the other elements. You can either get there by clicking the link right there from the preferred drug list, or from the main page in that blue ribbon, there's a link for PA criteria. You can bookmark that as well with this link here. So if you go to the PA criteria page, this is what this looks like. The organization of it isn't as good as you might see with like on the preferred drug list. Some of these criteria here are listed by the drug name. Some are listed by the pharmacologic class. And then in the case of like hepatitis C, it's listed by the condition. You can see right in the middle there, I've highlighted where the Hep C criteria is. If you click that, it'll bring up the full document of the prior auth criteria. So the top of the document looks like this. It'll link you to a few important documents that you need to either reference or to submit with your prior authorization request. So it has the prior auth form, it has the patient provider agreement form, which is also required to be submitted with the prior auth request form. There's a link for the prior auth continuation form as well. We don't see that really getting used very much anymore. That one's one you'd submit if you have a patient who's on a regimen that's more than 12 weeks in length. But most of our treatments now are 12 weeks or less, so we don't really see that one used very much. But it's there if you do have a patient who's on something that long. And then there's also the link for the treatment algorithm and preferred regimens. As we know with a lot of the Hep C medications, one medication doesn't treat all. So that document will kind of break down and say, like, for a specific patient scenario, which regimens are preferred on Medicaid. And that'll link you to that, and we'll go over that a little bit too. So what I'll go down is just there's 9 bullet points for the criteria. I'll just go through each one and just kind of give a few thoughts on each element there. The first one that they require is that they require that it be prescribed by or in conjunction with a specialist, like gastroenterologist, hepatologist, or infectious disease physician. And it says right there in the criteria that this program, the ECHO program, is considered a form of consultation. So if you're not a specialist, just document on the form, usually in the other pertinent information part at the bottom, consulted Project ECHO with whoever gave the recommendation there and their contact information. We consider that as meeting that part of the criteria. The next bullet point requires that the patient prescriber agreement be completed and submitted. So that was the link is right there at the top of the document of where that form is. It just has a few things that the patient has to agree to and the provider has to agree to too. We'll go over a few of those as we get through the criteria here. The next bullet point is that the patient has to meet the minimum FDA approved age requirement as specified in the package label. Most of those are going to be 18 and up. Mavorite is one that has 12 and up, or if they weigh 45 kilograms or more, and then you have Harvoni, who's indicated for 3 and up. If you remember from the preferred drug list, the Harvoni was not a preferred medication. And we'll see one of the later criteria here kind of opens it up and says, if there's no preferred drug that can treat that patient, as long as it's evidenced in guidelines and it's FDA approved for that age group, we can approve that for them. So this slide also just kind of goes down through each of the currently available options and what age groups they're indicated in as of right now, but those things are always fluid and changing. The next bullet point requires that the patient have 2 viral loads at least 6 months apart. Kind of the goal of this criteria was a little bit twofold. One was to kind of ensure that the patient is in fact chronically infected. 15% of patients who have HCV RNA in their blood at any point may cure, they may clear the virus on their own. So that's just one way to kind of make sure that they are in fact a chronic infection, not someone who is going to clear it on their own. The other part is to kind of make sure that this is the type of patient who is going to follow up, and who is a motivated patient who's going to take and complete the treatment and follow up and get through SVR12. We have this, they require the 2 viral loads be at least 6 months apart, one of them be within the last 6 months. The exception to that is if the patient is diagnosed over a year ago, just 1 viral load from the last 6 months is good. What they kind of mean by that is maybe you don't have the viral load from, maybe they were diagnosed in a different facility 3 years ago. You have that documentation, but you don't have the viral load. You can just document that on the PA request, diagnosed 3 years ago, wherever, and attach that note or whatever in that documentation and have the viral load from the current visit. That would be enough to kind of satisfy that requirement that they are in fact chronically infected. The next bullet point is that the prescriber must attest that the patient has abstained from the use of illicit drugs, excluding marijuana, and not abused alcohol for the last 3 months. That attestation is going to be completed on the patient-provider agreement form. There's boxes for the patient to check and the provider to check as well. There's also the requirement that the patient be vaccinated against hepatitis A and hepatitis B or be currently immune. We don't require them to have completed the series. So if they've just started and they're, unless they have a dose that's due right now, we would be able to approve it for them. If they do have a dose that's due, you just give them the dose and then they'd be meeting that criteria. So we can either accept the vaccination record showing they've got the doses, what doses they've gotten, or if you have antibody testing showing that they do have antibodies against Hep A, Hep B, that would also meet that criteria. Just as a side note there, Medicaid does cover all of those vaccines at the pharmacy for patients who are over 19. So if it's something where the patient lives a ways away and they're not in front of you right now, it's not something necessarily that they maybe need to wait until their next visit to come and get. You can just instruct them, go down to Walgreens or Kroger or whatever their local pharmacy is and have them get that shot, and then the PA can be run through without even having to see you again. This slide's just here for reference, just all of the hepatitis A, hepatitis B vaccines and the dose schedules for them. The next part of the criteria is that the patient and prescriber have to agree that the SVR12, the viral load taken 12 weeks after they complete treatment, will be collected and submitted to West Virginia Medicaid to confirm that they have therapy success. Medicaid has the ruling that a patient they'll pay for one successful course per lifetime for patients. So the SVR12 is only going to help establish whether that course is successful or not. If the patient doesn't follow up and get that SVR12 taken, then Medicaid assumes that to be successful. So if they do follow up and have that 12-week viral load taken and it's positive, then they'd be eligible to be retreated again. This is something that Medicaid I know in the past they've always had that requirement, and we haven't really had those submitted. There hasn't really been an avenue for the submission of those viral loads. So Medicaid's kind of tasked us with trying to reach out to providers. So any regimens that have been approved since October 1st, we started a program right now where Rational Drug will be faxing the providers, letting them know, it's been about 12 weeks from when they would have completed their regimen based on when the treatment was approved. And it's time to have them in. If they have been in, here's the form, just submit it to us and we'll keep track of them. It's going to be sent to the fax number that's put on the PA form for the prescriber. So we're using that as the contact point. If we don't get a response at week 12, we'll send it again at week 14 and week 16, just as reminders to make sure that those are coming in. The next slide here has just a picture of what that letter would look like, just a template. So the first ones of those, the 8-week Maverick regimens that were approved at the beginning of October, those would be reaching 12-week SVR around next week. So some of you may start seeing those letters coming to you. Just if you see those, that's what they are. There's a section on there too for comments too. So if they haven't followed up or if something happened to you can always fill out the comment part there and send it back if you don't have the viral load yet. And surely any documentation is better than nothing. The next part of the criteria is kind of a common sense part. It says if you're going to give them a protease inhibitor, so any of those medications that end in Pravir, those ones are contraindicated in patients with decompensated cirrhosis. So Medicaid's saying they won't approve them for those patients. I think that's pretty straightforward. There's a section on the prior authorization form that asks for whether the patient has cirrhosis and whether they're compensated or decompensated. The only thing I'd say with that, sometimes we will get some that say they're compensated. I've seen a few where they say they're compensated, but then looking at their medications, they're on lactulose, Xifaxan, propranolol, Lasix. That would be the only thing I think of what I would ever question a thing that's put on there, just to make sure, just to double check, because these medications could potentially harm a patient if it's given when they do have decompensated cirrhosis. And this is the last bullet point, I think, is the one about pediatric patients. So they're just basically, again, saying if it's a non-preferred medication and the patient does not meet the FDA approvals for the preferred regimens, as long as the HCV guidelines from the IDSA and AASLD recommended in those patient groups, we can approve for those. So those would be, for example, Mavorite if the patient's over 12 or over 45 kilograms, or Harvoni if they're over 3 years of age and have genotype 1, 4, 5, or 6, and they're not cirrhotic or they have compensated cirrhosis. So that was all the criteria. The final part there is where we'd spoken before, kind of about the treatment algorithm, preferred regimens. I cut a couple pieces out. The actual attachment is a few pages long, but the top box there kind of shows you an example of how they break it down by genotype and patient scenario, and they'll tell you which regimens are preferred. So for genotype 1A there at the top, you have the first checkbox, treatment naive and non-cirrhotic. It says Medicaid will prefer either regimen 1 or 5. So you scroll down that document a little bit, you'll get where the bottom box there where it has each regimen number. So if you line those up, you'll see that the options for that patient would be either Mavorite for 8 weeks or regimen 5, which is Epclusa for 12 weeks. It gets a little more complicated if the patient's a little more complicated, but that's kind of how you can line up which ones are preferred and which aren't. One kind of thing to point out where there's a little bit of a discrepancy, if you remember from the preferred drug list, that we did have listed preferred drugs, Epclusa, Mavorite, Zephyr among our direct-acting antivirals. So if you look at this preferred regimens list, Zephyr is not any of those, not including those regimens at all. So we've kind of asked Medicaid, is Zephyr preferred or not? Because there's not really an avenue for it to ever be approved. We're waiting to hear back from them. If you had a patient who you felt Zephyr was the best option for them, I mean, obviously this attachment here is not going to suggest it. As long as you put some reason on there as to why you felt Zephyr would be better than one suggested there. I feel like we could probably approve it if it was justified, but until we get a firm answer how they want us to handle those, if the other options that are suggested there are suitable, I would just go with one of those. Cool form. This is what the patient-provider agreement looks like. It just has a place for the patient to fill out their name, and then the top few boxes there are what the patient will fill out, and then the bottom couple boxes there where the prescriber would attest to and sign as well. So once you have all of that, you get it together and fax it over into us. This is pretty much everything that you'll want to send in to us. You have the completed prior auth form, the completed patient-provider agreement, 2 HCV RNA viral load lab reports would need to be attached to, or if it's one of those patients that we talked about where you only have the one, but they were diagnosed over a year ago, as long as you have that note in there as well. send those in. The genotype lab report we need attached as well, and the however you verified that they had their hepatitis A and B vaccinations done, we attached to. You can send those in, and our turnaround time once we get it would be within 24 hours. You either get an approval, denial, or sometimes we'd have to pend it if there's not enough information was included, but should be expecting it within 24 hours. If you don't get a fax from us, just give us a call and we can let you know where it stands, what else we need. This slide kind of refers to the, I kind of said we go over a little quickly how other states compare to Medicaid. A good resource for that is the stateofhepc.org website. It breaks down the Medicaid coverage for every state in the country. It gives a grade, and it kind of will break down, how is the state doing on liver damage restrictions, how are they on sobriety restrictions, prescriber restrictions, and then it gives a letter grade overall. So right now, West Virginia is a B-, which is comparable to like where most of the other states nearby. Pennsylvania, they give a little bit higher grade, and Ohio a little bit lower. One thing that was kind of interesting with most of these other states is when West Virginia has just their Medicaid goes through just rational drug use to PA. It's all fee for service for all the Medicaid patients. You don't have multiple pharmacy coverage Medicaid plans. There's not like in other states you have multiple MCOs, or they might have different criteria for each MCO. So it's a little bit easier to navigate with just having one set of criteria for all the Medicaid patients instead of 6 different plans, multiple plans like that for different states. Without going too in-depth to any of those, I just refer you to that site for your specific state. It pulls together a lot of good information sources and can link you to the right places where to find more information. So it was all about Hep C. I can pause there if anyone had any questions about Hep C before we go on to HIV.
Could you discuss the rationale behind non-coverage of reinfection?
That was something that they put in like right from the start with direct-acting antivirals. I think part of it was just that they wanted to make sure it's like cost control, make sure that patients who are motivated to be treated, hopefully are ones that are gonna, whatever behavior led them to get infected they would correct that behavior. And hopefully that's what a lot of providers would be doing too, would be linking them to care. If it was substance abuse, linking them to substance abuse treatment, linking them to syringe exchanges they are gonna continue using. But I think that's kind of what the rationale was. It is something that I mean could change down the road, but it's.
Is that over the lifetime of the patient? Because not all patients are lucky enough to be able to be ready to with those behaviors, to have access to the services that are needed to change those behaviors.
Yeah, the way the criteria is written, it is per lifetime. But I mean, if you had a patient who, I mean, you can always appeal any of the, so if it is a second treatment, it was a reinfection, you can always submit a letter of appeal. And I think putting any of that information in there as to what is different this time, what progress has been made that would lead this to be a successful treatment would be something that would be just be justified. Be something that would help your case, I think. Sure, cat. Any other questions for Hep C? Oh, great. Appreciate it. So I'll go on here to HIV therapies. HIV is a little bit simpler in that there's not a 12-page document of how to get the medications approved. This one's pretty much just covered by the preferred drug list. So there's nothing on the PA criteria page. The preferred medications, they don't need prior authorization. So if you pick a preferred one and you write the prescription for it, the patient takes it to the pharmacy, it should go right through for them. The non-preferred medications, those ones, they're available, but there has to be medical reasoning why that non-preferred medication is used and why the patient can't just be treated with a preferred medication. It has to be more than just compliance or convenience. A lot of if a medication is not preferred, there's a lot of preferred medications a lot of times that you could use just 2 of those to make the combination product, the combination non-preferred product. There is the clause that they have that if patients were already on the non-preferred regimen, Medicaid's not going to make them change to a preferred regimen. We can grandfather them so they can continue what they're currently on. But if you do want the patient to be grandfathered, you would have to give us a call or a fax to let us know that they were on the medication. Sometimes we just require just pharmacy records showing, you know, here's where they filled it the last few times, and we can just approve that for them. So in January, there were a couple changes to preferred drug list. The ones that moved from preferred to non-preferred, there was Edurant and Truvada. Truvada is the one that is used a little bit more outside of just treatment, and there's a little bit of intricacies with that. So Descovy, which is a pretty similar drug, has emtricitabine, and the newer form of tenofovir AF, that one's preferred. You could also get the same Truvada treatment with Emtriva and tenofovir DF, which are available as separate ingredients, and those will go through without prior auth. Medicaid's realized, though, that Descovy doesn't really have the FDA indications or research to support pre-exposure prophylaxis if the patient's at risk for receptive vaginal sex or from IV drug use or for post-exposure prophylaxis. So if you wanted to still use Truvada in those cases, your two options could be, you could either write in Emtriva and tenofovir DF separately, or if you wanted to use Truvada by, you know, the combination product, Medicaid's allowed us to approve that. For those situations, you just have to give us a rational drug a call or send a fax in saying that's what you're using it for. The ones that move from non-preferred to preferred, Complera is not preferred, and Delstrigo is also preferred. The next couple slides are just kind of just reprints of the preferred drug list. They're just going to show what's preferred, what's non-preferred. They're just kind of there for reference. So there's a few pages of this, but these are the two. So you need this for reference, or also just go to the preferred drug list online, and that'll be the most up-to-date version if anything were to change. And the last slide I had was just about the Ryan White program. The limited pharmacy service plan and the AIDS drug assistance program, kind of the same thing. They're billed to the through the Medicaid card as well. They're a little bit different formulary than full Medicaid. The last formulary I have the link there that I was able to find was published in February 2015. I'm not sure if that's completely up to date. But in order to be eligible, you just have to be HIV infected, resident of West Virginia, have income less than 400% of the federal poverty limit, that did not be eligible for other forms of insurance coverage, and they just have to apply at the DHHR county office for that program. The only requirement is that this program be the payer of last resort. So if they do have some other insurance, they could still qualify for ADAP or limited pharmacy services. It's just they would be billed last. They pick up the copays basically.
Great, thank you so much for that. That's wonderful. Did anyone have any questions about that didactic or comments?
I'd like to make a comment. This is not gonna like
Shocking.
This isn't gonna sound this isn't gonna sound very nice, I'm afraid. But the idea that restricting access to medications from a cost-saving perspective with patients that continue to struggle with addiction is in any way beneficial is categorically stupid. Like, anybody that has more than a basic understanding of fourth grade math understands that those would be the people that you would want to prioritize treatment for to mitigate the spread of disease. And anybody that asserts anything else is actually just logically false. Like, it's just obviously, it's, you know, but unfortunately we allow things like our personal opinions about behaviors that we deem less than desirable to affect some of those policies. And I'm afraid that actually that's what that is as a matter of fact. So anyway, I just happen to have the lack of class to say that.
I've said it
It's
before.
not Chris's fault, though.
Yeah, not your fault.
So the example I give is syphilis. You know, people get syphilis over and over. We're not going to restrict. Of course, penicillin's a lot
cheaper.
But, you know,
Yeah, I mean,
you
to be
wouldn't tell somebody that once in
to
the
be
future.
fair, the vast overprescription of penicillin has been the downfall of getting to see syphilis, and it's true. So we don't get to see that. And these medicines are $80,000 a piece, and I understand that that's a big deal. But I'm afraid that the lack of access that we have to sift through. I'm very enthusiastic about how much better it's getting in West Virginia, and we should all be very, very happy and proud of the fact that that's the case. Hooray!
I think I want to run for office, man.
Yeah, well, I'm really, God bless you for that sentiment. I think it's important for all of us to realize that West Virginia not being a very wealthy state, this was a big, big, big commitment on the part of Medicaid to do this. And so it really behooves everybody who's treating to make sure you get people back in for their SVR 12, because if Medicaid has trouble proving to the funding, the people who vote on the funding, that we are not actually accomplishing something, we may sadly feel an outcome from that. So, but it is a terrific thing. That was the single biggest barrier, because we have ECHO and because we have this other training program that a number of us are involved in. You know, I think for the time being, the specialist requirement is kind of the least significant obstacle. And unlike other states, West Virginia doesn't require a drug screen. So, you know, I think there's reasonable leeway in all of that. But we got to get them back in. And you guys and gals are doing a great job. Very much.
Anyone else have any comments to say, or before we part ways, any questions?
The only thing I just want to add, I have a med student, Ash Shempy, is here with me, a third-year medical student from WVU. So she got to enjoy this today too.
Oh, I'm so happy. Thank you.
Good learning. Yeah.
Thank you and welcome.
Hey, John and Dr. Feinberg, if just real quick, since we're wrapping up, we're starting a Hep C clinic here with CCWV, and the idea is that it's going to be a multidisciplinary team approach towards it, with our MAT, and then with also our behavioral health, and then clinical pharmacology, and then me, and to treat people. But we've done like kind of preliminary numbers to figure out what exactly that's going to look like, and I think our goal is probably going to be to treat about 100 cases of hepatitis C this year. The vast majority of those are going to be Medicaid patients, and if there was a way that maybe we could like touch base and like so that I could kind of batch those people, you know, kind of get those submitted, and do stuff as an outsheet, like however that would work best for you, I'd be glad to figure out something so that it would be the least amount of, you know, I don't want to jeopardize all your time doing stuff or stuff. But if that was something that we could
absolutely, man. Yeah, we can talk about mechanism wise. Kaylee and I have been getting these on-demand ones on occasion, and Katie's been better than I am about doing them. But no surprise to anyone who knows us.
We can
we can take care of it.
Yeah, we can certainly discuss that. And I really congratulations to you and to your organization, because I think that's a wonderful step to take.
Yeah.
You know, all the data shows that co-located and integrated care is the best way to deal with a challenging patient population, the vast majority of whom have current or past drug use in their histories and are struggling on many levels. So I think that's fantastic.
Greg, have buy you a elastography.
Yeah, right. Talk to Letitia, she
Yeah.
knows how to do it.
Dr. Tierney,
I think
Do
they
it.
would. It's
Do it.
that's good.
Hey,
But thank
pay
you
for
guys very
itself.
much.
Yeah.
it actually will pay for itself. And
Yeah,
you can
it does.
avoid paying, and you can avoid buying those expensive fibro tests and other money makers for laboratory companies.
Yeah. And the way I make it affordable, if it comes to that, Greg, is I do a visit with it so that I can get an office visit as well as charge for the FibroScan.
We're ahead of the game, Letitia. That's great. Learn from the master here, Greg. Mistress, master, mistress.
Doesn't matter, that's all good.
There's gotta be a word.
It's gotta be work. I don't know what it is.
Thank you all.
Before we part ways, Caitlin just had a quick announcement to make as well.
Yeah, it was just a plug for that HCV on demand. We've had a couple people taking advantage of it, but Dr. Peters especially for this. If you wanted to batch in cases, all you have to do is just put in the comments for on demand, and we'll get back to you without them having to be part of the session and stuff. And they basically go to the hub, and mostly Kaylee is getting back to us. But that's okay. So
we're doing a treatment. We're developing, basically it's like a treatment sheet, and it's for our record keeping on our side to just follow these people through their treatment so that they get everything that they need to have and had it done at the correct intervals. And we're probably going to actually submit that to Medicaid and then the private insurers, because it'll have all that stuff in one place on one sheet in addition to the prior authorization form. It might even be easier just to have that. I mean, I don't know how you guys would want to do it, but it's just like that sort of stuff. Hopefully it'll all be kind of, we're trying to streamline this as well as we can, so that we can do less individualization of the paperwork and more individualization of the care. It's dumb to have to say that like that, but it's like, anyway. So
no, we understand. Yeah. Definitely try scanning that and sending it to us. Just email it over to Mitra and I, because the people we've had taking advantage of it have been sending in their own stuff. So we'll see if that will work.
Thank you guys so much. I can save both your cases for next time if that's okay with you. We can touch base again through email.
Yeah, and that's fine, unless, if there's somebody else new who submits a case, then it's fine to bump mine, because I'll talk to somebody and get them treated anyway, so it's fine.
Perfect. Thank you. See you guys next
So far.
time.
From me.
He got away yesterday. You want to talk tomorrow at noon?